Today we have got Dr. Praveen Shankar, eminent diabetologist from Ranchi with us, and we would try to address the metabolic menace that we all coming across. As we all know that we are having double pandemic. On one side, we are having a metabolic menace of diabetes involving a huge section of the whole nation. At the same time, we are slowly recovering from the infective menace of COVID-19 infection. Now, at this junction, unfortunately, we have lost quite a significant number of our friends, juniors, seniors, and unfortunately, most of them, the single large issue that we had seen, we have lost them because of the cardiovascular and renal events, be it stroke, fatal, non-fatal myocardial infarction, or renal compromise. Probably this cardiovascular renal continuum have caused a really significant toll all across the nation. Dr. Shankar, would you agree on this point that we probably need to look into the whole context a bit more seriously, more aggressively, more comprehensively?
Good evening. Yes, I totally agree with you. I think we have, in some way, we have failed to fully and effectively manage our patients so far. And I think now we have got a very potent armamentarium in our basket in terms of anti-diabetic therapy, where we can address metabolic problem that we are facing with our patients.
While selecting such molecules, would you mean that we would be looking into molecules with proven cardiovascular outcome trial data, having mortality benefit, having renal safety data, which have got significant renal positive data, that capacity to reduce microalbuminuria or ability to deter the renal decline in EGFR, requirement of renal replacement therapy, or for that matter, reduction in cardiovascular events?
Yes, exactly. Yeah, I mean that.
Looking by the class over the last 5 years, since the day of Empagliflozin, that's 2015-16, which have significantly changed our perspective. We've been looking into SGLT2 inhibitors, especially the Empagliflozin, because of very hard mortality benefit data. Would you highlight on this? What is your opinion? What is your experience on this?
Yeah, actually, the Empagliflozin trial was the first trial which demonstrated the renal mortality and morbidity benefit with a anti-diabetic agent. And this finding of this Empagliflozin study has changed the whole approach to glycemic management of patients with type 2 diabetes. The data which came from Empagliflozin was very robust in terms of decreasing cardiovascular morbidity and mortality. And subsequent analysis of the Empagliflozin trial also demonstrated the benefits in terms of diabetic kidney disease and heart failure as well. So after that, other molecules of this class, like dapagliflozin and canagliflozin, they also went through their randomized controlled trials. But the kind of robust data in terms of cardiorenal benefits that we have got with empagliflozin was not matched by dapagliflozin or canagliflozin.
Taking cue from your words, Dr. Shankar, if we look in a little bit more closely, Canvas and Canvas R data, if we look into canagliflozin, unfortunately, probably Canvas was, I will be saying, compared to the other two molecules, probably it was a less capable molecule. Unfortunately, we had a big hope that probably Canvas will be coming up quite positive in view of that the canagliflozin having both SGLT2-1 and SGLT2-2 inhibition. But unfortunately, instead of having a very profound glycemic benefit or a superiority, we had more requirement of fall, more incidence of fall, more amputation, more adverse effects rather than positive signals.
Exactly.
Probably people tried to generalize the whole thing as a class effect, but unfortunately, the A2 gliflozin data that came up in the Vatis CV have once again failed miserably to show any mortality thing.
Yes.
Whatever DAPA data we have got, it doesn't have any mortality benefit that of EMPA. So probably in terms of reducing the major adverse cardiovascular events and
Yes.
especially the cardiovascular mortality, probably EMPA-REG and subsequent EMPRISE and other data are quite robust and quite compelling, quite persuasive p-values probably we have got. Dr.
Yes.
Shankar, what is your take on its counterpart? Like we all know, if we put someone on a SGLT2 inhibitor, a person starts being more glucose, and as a result, the compensatory glucagon axis gets activated. So glucagon axis might somewhat compromise the effectiveness of glycemic control of SGLT2. So how you consider the complementary action of SGLT2 inhibitor along with an appropriate DPP4 inhibition like linagliptin complementing each other in this context?
Yes, actually, this gives you more advantage in terms of glycemic control as well as cardiovascular risk reduction. And the other significant gain that you have with this combination is that the chances of genital mycotic infections are also considerably less when you combine these two molecules. So yes, definitely combining empagliflozin and linagliptin is a win-win situation for us clinicians as well as for our patients, both in terms of benefits, in terms of cardiovascular and renal morbidity and mortality, glycemic control, and reducing the side effect profile.
Quite expectedly, as the gliptin use would reduce not only the glucose load that is coming out of the urine and
Yes.
thereby reducing the risk of genital mycotic infection or rather pyogenic infection, aerobic infection. At the same time, the fungal flagella, candida especially, which contain DPP4 and use of DPP4 inhibition would prevent proliferation of the fungus. That's also a huge issue.
Yeah.
That's
Yeah.
a glycemic benefit that we get.
Yeah.
Dr. Sarkar, one more point I would like to learn from you. You being a very senior clinician, you might be
Yes.
seeing quite a huge number of patients, and the issue of dropping out, not coming up on follow-up, while the renal function progressively deteriorates as it's a progressive disease, and eventually creatinine clearance compromising prescription safety. For example, sitagliptin, we need to reduce 3 level from 100 to 50, from 50 to
Yeah.
25. For
Yeah.
Vida, we need to reduce from 100 to 50. But Lina, for that matter, probably will be a safer thing. So what do you consider from your experience? What is your take on this point?
See, if you are a patient, the only thing that you will look into is that how your sugars are getting controlled. And when you use this fixed dose combination of Impalina along with metformin, you are using a very effective anti-diabetic agent, which will provide you very effective glycemic control in your patients. So that is the thing that motivates the patient to stay on the treatment and come back to you and get continuously followed up with you. So that is one point that makes your treatment very effective and very accepting for your patients.
Dr. Shankar, one more thing I feel quite reassuring that both SGLT2 inhibitor, empagliflozin, and DPP4 inhibitor like linagliptin, which
Yes.
are practically having no or zero or pretty low, absolutely almost zero level of hypoglycemia risk involved. So
Yeah.
that's probably one more thing there. Good adherence is quite expected, and patients won't be fiddling with the drug or skipping the drug in fear of risk of hypoglycemia or weight gain for that matter, or requiring to snack in between. What is your opinion on these issues? I think these are also clinically quite useful points that if we share with our patients, they will find it quite helpful and they would probably continue the molecule without fiddling with the dose. That's a very common risk that we come across with our patients who try to fiddle their dose.
Yeah, definitely. I have got a very significant number of patients who are on this combination of fixed dose Lina, Empa, along with metformin, and they are able to achieve HbA1c below 6.5. There are certain patients who are into HbA1c less than 6%, and they are not getting any problem, no hypos, no other discomfort they are feeling, and sometimes they are very they get very motivated because of that okay, this doctor has treated me so well, my sugars are so well controlled, and they tell other patients as well, and you get a kind of advertisement from your patient that see
It's
this
very
doctor is.
reassuring that the patients are getting the benefit of the science
Yeah.
and they're sticking to the regime and they are having
Yes.
confidence on the
Yeah.
molecule that they are having. And that's a very
Exactly.
positive feeling they are carrying that.
Yes.
And I'm sure they might be using for quite some time as you have got a huge number of patients on these. Sir,
Yeah.
what about the events that were coming? Are they really having a good course, not requiring much complications, not hypoglycemia? Because I expect there will be a very little glycemic variability in these patients.
When they are started on this combination therapy, they continue on it, and I have got a very good number of patients who have continued on this medication for almost 3-4 years, and many of these patients, if they were having diabetic kidney disease and their albumin to creatinine ratio in urine was very high, that has also come down. Their blood pressure is controlled, they have lost some body weight as well, and these all facts are very motivating for the patient.
We as
Yeah.
clinician probably would love to hear this portion because we often come across seminar medicine and seminar discussion of persuasive p values and others. But while
Yes.
getting that translated into our daily clinical practice, it is
Yes.
really very reassuring that
Yes.
adapting a standard proven thing in real life evidence when you get to see the benefits of empiric benefits of other things are
Yes.
getting into. One more very basic question for our primary care physicians who might
Yeah.
be listening our discussion. To how low EGFR you are happy to use this combination? 25,
Uh,
20, or around 30? How low you consider is safe to go with this combination to initiate
um,
follow-up?
uh, 30 up to 30 I use them. The thing is that as the EGFR goes down, the glycemic efficacy of the molecule goes down, obviously, because there is less glucose coming in the urine to act upon. So once the EGFR goes down, then the glycemic efficacy comes down. But at that point of time, this medicine works as renoprotective medicine. So in that way, you can use this medicine. But EGFR below 30, I don't use.
After all these renal data,
Yes.
uh, I have also started using up to 25 and found it quite effective up to the level of 25 as well.
Yeah.
Obviously, we are not looking for diabetic control only.
Yeah. Yeah.
Obviously, we will be using in combination. Maybe
Yeah.
metformin use will be adjusted. One
more
more thing
more
I would like
more
to
like a renal medicine in that situation you are using, like you are
absolutely.
using ACE inhibitor or ARB, in the same way you are using this molecule as well.
Dr. Shankar, how frequently you come across heart failure these days? Does this combination use really protects the post-AMI patients or similar patients who were otherwise at the risk of having ECF overload or heart failure and other comorbid issues?
Yeah, I routinely introduce this medicine to my patients who are suffering from ischemic heart disease or congestive heart failure. And many a times I have to explain them the value of this particular molecule to them, that the way you are using your aspirin or your statins or your ACE inhibitors, the same way this medicine also works, and this will protect your heart. And after explanation, most of my patients accept this medicine and they get benefited in terms of reduced hospitalization for heart failure or worsening of heart failure. So they definitely get benefited. So anybody coming with established ischemic heart disease or congestive heart failure, I routinely introduce this medicine to them.
Dr. Shankar, I've got just last two questions for you.
Yes.
Last question is, we often come across a huge wide spectrum of patient and we talk about individualization of care. Uh,
Yes.
to your understanding and to your teaching, what you would like to tell us on this thing? How you individualize a person? What are the points one should remember? This is once again for our primary care physicians who come across huge number of diabetic patients and they try to focus A1C or fasting or prandial glucose lowering as the primary target. How we should be looking into our patients for their perspective on individualization of care.
Okay. So individualized therapy is very important nowadays. You should not approach your patient like you are seeing a herd of people. Each patient is different from another one. So if you see a patient with coming with diabetes, the first thing I will look into is the comorbidities, whether the patient is suffering from any comorbidities. And if the patient has got cardiovascular disease or multiple risk factors for cardiovascular disease, patient has got heart failure, or patient is suffering from diabetic kidney disease, my approach to treatment for them will be different from somebody who just has got type 2 diabetes. So that is one thing. The second thing I would look into is the uh, economy of the patient, how whether the patient can buy the medicine I'm going to write to them. Unfortunately, impa lina combination FDC is still not affordable for many of our patients. So I look into that, whether they can buy that medicine or not. Then I will look into their social situation, how the person is elderly, living alone. Um, then you have to go for medicine who will give the patient very low side effects, especially very low risk of hypoglycemia. So in that situation, impa-lina combination along with metformin is very safe and very effective. Effective in terms of in terms of reducing blood sugar, and safe in terms of having minimal side effect profile. And then I will look into other factors like whether the patient has got any side effect from before, like getting frequent urinary tract infection or getting frequent fungal genital infection. So in these kind of patients, I would probably not start them on SGLT2 inhibitors. Then I will discuss the treatment that I'm proposing to the patient, because if I'm writing a prescription and simply handing over the prescription to the patient, that is not going to do my job. I have to talk to the patient. I have to tell the patient why I'm giving this medicine, what are the advantages that this medicine has got. And once the patient understands, then I write the prescription. So in that way, I think the compliance to your treatment improves significantly, and your treatment becomes very effective in patients. And then if I start the patients on SGLT2 inhibitors, I tell them two things. I tell them to maintain hydration, drink at least 3 to 4 liters of water every day, and to maintain perineal hygiene. And I tell them that if they get any dysuria or any itching or any whitish discharge or deposition on their genitalia, they should immediately come back to me and tell me about these problems so that I can look into them. So these are the things that I do before prescribing this medicine.
One just last question, kind of last question. It's really nice to hear from a learned senior clinician like you. Uh, Probably we're changing from step by step, one after one protocol of adding one oral anti-diabetic agent on top of the another one to starting early with combination regime. Do you consider this FDC should be initiated early, and do you consider that early use of a molecule like empagliflozin, which has got proven cardiac as well as renal protection data, along with complementary action of linagliptin, which has got excellent safety data, which has got excellent proteinuria reduction data and data like Toscaity and others. Do you consider that early adoption of this combination can translate into really meaningful halting the progression of cardiorenal continuum? And what will be your take-home message for such? And with that, we'll conclude.
Yeah, definitely. I agree with you that if you go for early aggressive treatment, then you reap the benefit of that treatment in long term. And that has been well proven from the UK PDS follow-up study, which showed that there is legacy effect of good glycemic control that translates into reduced cardiovascular morbidity and mortality in long term. So definitely, when I start my newly diagnosed patients on with type 2 diabetes on anti-diabetic therapy, I tell them that, see, you have to look after yourself well for initially 5 years. It is like you are paying the uh, premium of your insurance policy. Your insurance policy is for your life coverage, and that covers you lifelong. But you pay premium for a certain period of times. In the same way, when you are starting treatment for your diabetes, if you pay attention to your treatment and try to achieve very good glycemic control for initial 5 to 6 years, that will be translated into long-term benefits for you. So that's how I try to motivate my patients to start to stay and to achieve good glycemic control. And when I'm starting them on treatment, most of the patient I start with metformin monotherapy, and if their glycemic control is not good, I try to move on to this FDC combination of Impa Lina as the second line treatment.
Thank you, Dr. Shankar, for such enriching interaction. With your message, I understand our viewers will be greatly benefited, and the understanding of cardiorenal continuum and early adoption of appropriate fixed dose combination would translate into clinically meaningful benefit for our patients. Thank you.
Thank you.